So today we're talking about infections. It's January 17th, and right here, what you'll see is we've got this really great worm. So this is a parasitic worm. We'll talk more about that later on. All right, so first and foremost are types of infectious agents that are most relevant to human disease. We have three major classes. We have our acellular, our prokaryotes, and our eukaryotes. And with respect to our acellular pathogens, we have viruses, viroids, virusoids, and prions. Prokaryotes, we've got bacteria, and our eukaryotes are those larger things. These are often multicellular, like our protists, our fungi, and our helminths, or our worms. And so, just going back in history a little bit, because I thought this was really cool. Dmitry Ivanovsky, who was a botanist, so a plant scientist, was credited with the first or with the discovery of the first virus in 1892, the tobacco mosaic virus. Now, this was done through exclusion, which I thought was really neat. So, just a couple years before, Louis Pasteur in Paris had invented a filter, and this filter could filter things down to 1 micron. And so the idea was anything that was able to be filtered through, like or anything that was too big, like bacteria, would get stuck above the filter. And what Dimitri saw was that the infectious agent passed through the filter, meaning that it was smaller than what they recognized as the smallest bacteria. And so it had to have been something else. And so they coined it a virus, which is Latin for pathogen, I think, or toxin. So not even did we get the naming right, right? But years later, it was discovered that it was actually nucleic acid containing thing, because we can't call it an organism. They're not living organisms. But it was something that was not a bacteria, smaller than a bacteria, but could still be infectious. And so that was just something that was really neat. And with respect to like our bacteria, all of this work was done like 200 years ago. And so we had some really awesome discoveries that were made 200 years ago before what we have right now for modern science. And so we have Louis Pasteur right here, and we have Robert Koch right here. And both of these gentlemen ended up making some incredible discoveries in the field of microbiology and immunology in particular. And so Louis Pasteur, I developed a lot of different microbial techniques or techniques for studying our different microbes. And Robert Koch actually spent more time identifying the specific microbes that caused all of these different conditions that people were suffering from, like anthrax, cholera, and tuberculosis. So pretty cool 200 years ago. And I bring this up because the fields of microbiology and infectious disease have been around for over 200 years. And for whatever reason, we are now questioning that science today. And so let me emphasize that viruses were first discovered in plants. So there was no conspiracy back then that, like pharmaceutical companies were driving these viruses or anything like that. The big thing to emphasize here is that viruses exist, bacteria exist, and there's no great conspiracy for their existence. They've always been around. So let's talk about kind of the size of things. So I mentioned our bacteria, right, which are, oh, right here. There we go. And so this is about 1 micron. And so that was what ended up leading to the discovery of these different viruses. And so what we see here is we have this polio virus, really small. It's about 10 nanometers. And we've got this flu virus, which is a little bit bigger at about 100 nanometers. Neither one of those can be observed using a light microscope, but then we start making it into the smaller sizes that can be observed by a light microscope, like our smallpox virus. And then of more recent news, we have the coronavirus, which is named because of this, the presence of these cell surface proteins that make it look like the corona of a sun. And so that was something that I thought was really neat. And then we have bacteria, which are a little bit larger. And then as far as our other infectious agents, like our eukaryotes, we have them kind of off the chart. They're quite a bit bigger. And so we might have this protozoa like Giardia or fungi like Candida. Um, And then our helminths, which are easily observable without a microscope. And those are like our roundworms down here. And then going all the way back, we also have infectious agents that are not organisms or viruses, and these are proteins or protein components. They're prions. And so here we have a normal brain, and then we have a brain with the prion disease, Creutzfeldt-Jakob disease. And so that is a prion disorder that leads to spongiform encephalopathy. And so when we talk about those types of things, those are things like chronic wasting in deer, mad cow in cows. There's a bovine version, and so these are all prion related, and so that starts with a protein. So I think it's really important to note that often one infectious particle is not enough, and so that might be a single virion, that might be a single bacteria. Usually it's not enough to create an actual infectious disease. And so this is kind of in the world of public health and epidemiology. So scientists talk about infectivity with respect to median infectious dose, or the ID50. And this is the number of pathogenic agents, cells or virions, that are required to cause an active infection in 50% of test organisms. So this is something that is done by scientists in a controlled environment. So this is not anything that's observed in the population. And so when it is done with tissue culture, we refer to that as the TCID50. And then we have the median lethal dose. And so this would be things like when you're studying anthrax, for instance, is the number of pathogenic agents that are required to cause mortality in 50% of the test organisms. And this is what that ends up looking like. And so you'll see that as the number of pathogenic agents increase, eventually we have 50% of mortality within the experimental group. This is usually done, this could also be done with cell culture. Usually it's done with like mice or rats, and sometimes other organisms. But right here, what we see is that we have a 10E4, so that's 1,000 pathogenic agents, resulting in 50% death across the experimental group. And then our last major tidbit, our major vocab, is our R naught. And this is shown with R0. And this one came up especially with COVID, because this was one of the measures that were being used to estimate the infectivity of COVID as it spread worldwide. And it's important to emphasize that this is an estimation and it is region specific. So it does have limited applicability outside the region in which it was calculated. So the R naught of COVID in China at the early stages of infection was almost certainly different than as it spread across the US or as it spread across New Zealand, who had a much better control of its spread. And so the R naught is relatively region specific. However, you can look at the R naught as an indicator of what could happen. So something that has a high R naught means that it is very infective or infectious, and it has potential to run through a susceptible population really easily. And so the things that are used in the calculation of the R naught is the duration of the contagiousness. And so if somebody is contagious for 2 weeks, that's going to generate a much higher R naught value than somebody who's infectious for 1 day. And then number 2 is the likelihood of infection per contact. And so does it require a lot of infectious material in order to infect another person, or is it just a one and done? And then also the contact rate. And so this has to do with how social we are as human beings. And so the ID50, I'm going to just spend a little bit of time with this because it is kind of interesting. So this is general infectivity of viruses. You'll see that, you know, when it comes to norovirus, which is one of our stomach bugs, 1 is enough. And it doesn't take much to get a whole place sick. And so that's why when we end up with norovirus or even rotavirus, where we've got, you know, only 10 infectious molecules, it spreads quickly because it spreads generally through a specific population, our kids. And our kids, who are usually not super duper at washing their hands yet, right? And so this is a fecal to oral transmission. And so all it takes is contaminating a toy, and then another kid puts that toy in their mouth, and it's just like, oh, that's disgusting, right? But that's how something like that spreads so quickly. And so it's not just the number of infectious particles, but also how it's contracted. And so hepatitis A and hepatitis B, that could be contracted through hepatitis B through blood. And so it could be as simple as helping someone clean up a cut. That is something. So if you're cleaning up somebody else's blood and you yourself have an open wound on your hands, that could be enough for transmission. And then hepatitis A, that's usually contaminated food and water, or actually contaminated food that has been like washed with contaminated water. And then we have bacteria. Yay! So we've got a whole subset of different pathogenic E. coli. It's important to note that so many people don't understand that our guts are actually covered. They have their own microbiome. So we have a whole bunch of different microbes that take residence in our gut, including E. coli. It has a lot to do with the environment in which they're in, whether or not they're pathogenic or doing the job that they're doing, which is helping us digest our food. It's pretty cool how our personal microbiomes help with us. And so we have a couple of the different E. coli pathogenic varieties, so enterohemorrhagic, enteroinvasive, enteropathogenic, and enterotoxigenic. Some of these are worse than others. Like these guys up here, that is the ones that can lead to like dysentery. And then salmonella. And so you can see that with some of these, it doesn't take very many. Um, with some of them, it takes a lot. So we're talking 10 million to 10 billion in order to come down with an active infection here. And so the higher that number is, the more infectious particles a person needs to be exposed to in order to come down with whatever infection it produces. And then we have protozoa. So Giardia is 1 and Cryptosporidium is 10. And so we have this really big difference between the infectivity of viruses, protozoa, and bacteria. And so they're all very different, right? And so the takeaway is that the higher the number, the more infectious particles are required for infection. But the ID50 does nothing to inform us about disease severity. And so for that, I emphasize, like these ones right here are particularly devastating if you end up with them. These E. coli infections are less devastating. They're more of a nuisance. They can be really terrible depending on the population that gets them. So be it an infant or our oldest adults. And so it also depends on that. But generally for a healthy adult, these ones are going to be very devastating. These ones less so. So some of that information is just accumulated knowledge, but the ID50 does nothing to inform us about the disease severity. And so let's move into the R naught. So the R naught is the reproduction number. And basically what this describes is how many additional cases of disease each infected person will cause during the infectious period. So if I came down with the flu, I could possibly infect you. And that might be where it stops because influenza is pretty close to a 2 to 1.4. And so it considers things like infectivity, which is the reason why I shared the ID50. And it also takes into consideration the susceptibility of the host. And so our R naught values are also potentially impacted by vaccination rates. And so how well a given population has been vaccinated. And then also the environmental considerations. People who are living in more rural spaces will have fewer interactions with people than as compared to people living in urban situations that ride public transit, for instance. So if we talk about the R naught values, what we have here, and then an important thing is if that number approaches 1, that means that it's going to just run stable. And so public health then says, well, what type of advice can we do to get that below 1? Because then you're going to end up seeing infection rates fall within a community. as opposed to something like measles, which is super duper infective. And that's why we're dealing with these crazy outbreaks in these different communities that don't have good vaccination rates. It's because measles lingers and it's so easy to become infected. And yeah, so the measles, for every one person who comes down with measles, the R naught is 12 to 18 other people are going to come down with measles. And so what we're observing too, or what scientists and public health officials and physicians are in belief of, is that we are seeing a dramatic underreporting of measles cases, because some measles cases are really mild, but the only ones we hear about are the ones that end up in the doctor. And usually you're not going to a physician's office if you're having a good time, right? And so, also in the current events is, COVID is still rampant or going through. And so that has an R naught of 1.5 to 3.5. That depends on the viral strain. It also deals with things like vaccination rates again and social interactions. And right now we have an estimated R naught of over 1.4 with the current influenza A that's going around. So that's the H3N2 strain. And I think it's like subclade K. And so that's what's currently the major influenza strain that's going around. Yeah, you bet. Yeah.
That's changed.
Yes, and that's why they have some of those have ranges, is because different flavors of COVID has a very different R naught as it passes through the population. Does that make sense? Or did you have okay.
Makes sense. I was curious. I don't know if you can compare like at the height of 2020
Right.
now, because like strains.
Yep. Yep. So that's actually a piece of information that I didn't include. And so the R naught can also be broken down into two varieties, one of which is the basic R naught, and the R naught basic actually takes into consideration what would happen in a completely 100% susceptible population. And then there's, I can't remember what the second R naught is. And that one takes into consideration things like, okay, well, we've had this pandemic go through. Now we don't have a fully susceptible population. And so there's different varieties of R naughts, but this one is, I believe, the R naught basic. And so it takes into consideration a fully susceptible population, because ultimately, as we move into different serotypes of COVID, different strains of COVID, and we lose our immunity because different COVID strains require different immune responses because it's mutating in a way that will then evade our immune systems, right? We're basically starting out from scratch all over again. So, yeah, right? Woo. And so then let's talk about susceptibility, because this is really important, especially as it pertained to what had happened in 2020. So with this whole, some people really felt like they got wishy-washy advice or they didn't understand. Basically, what it came down to is three major things: social distancing, face coverings and masking, and then vaccines. And so those are the three major ways that we can help control viral spread. And that is, if we all look back and are being honest with ourselves, those are the things that were discussed at length by our public health officials. Now, when we dive into the nitty gritty, the details of the different advice that was given, that's when people, I think, really lost uh, enthusiasm for following some of those different protocols that were put in place, or maybe they were confused. They didn't understand why, 1 week we were told not to wear masks. It had everything to do with making sure that our people who were treating these patients had access to masks. So that was the explanation there. And then the next week we were told to mask. And then, face masks that were made out of cloth were less effective than face masks that were N95. Well, yeah, but you know what? Face masks that were made out of cloth did the job of stopping particle spread because it formed a physical barrier. So the things that were able to get through were far less than if you were going unmasked. And so some of these things are so easy to explain, but they became politicized. So that's our knot with public health and epidemiology. And that leads us into, so I mentioned vaccines here, right? So I'm going to do a shameless plug for last week's presentation on the immune system. And so last week we did talk about the natural versus vaccine acquired immunity and how natural immunity is not actually a superior form of immunity, and it does come with significant risks. Of course, there's risk with vaccine related injuries as well. But generally speaking, those are at a far less degree than the risk that comes with an active infection. So, shameless plug for last week's presentation. So, this brings us to our last piece, which is I don't feel good. What can I do? Let's talk about how to treat what ails you. So the first thing is let's consider how it presents because viruses, bacteria, and fungi all present a little bit differently, generally speaking. Now, there's always oddball presentation patterns that you have to be aware of, but with respect to a virus, so with this, we're talking things like influenza A, COVID. It's going to be something that hits you fast, it hits you hard. You're generally going to feel bad all over. You might even feel bad in your toes. You're going to present with body aches. You're probably going to have some degree of fever. It might be really high, it might be low. It kind of depends on the virus and it depends on you as personally as well. With bacteria, often this is localized. So for this, I ask you to think about sinus infections. And so usually that's localized to right here. Chest infections, it's localized to right here, but you're not going to have achy joints, usually. And once again, this is very person specific. The thing with bacteria too is that it often follows a viral infection. And so in this way, we can talk about some bacterial infections as being opportunistic, and usually bacterial infection will present with a fever. And so talking about sinuses, what we have over here on the left is a healthy sinus. So these ones, we don't have a lot of inflammation in this ductwork. So everything is moving, breathing. All of the microbiome that lines our sinus cavity is healthy. It's, doing what it needs to do. But once we end up with sinusitis, we have inflammation in those ducts. And so as soon as that inflammation happens, we go from having a passage like this that can breathe, figuratively speaking, not physically itself, right? But the air can pass in and out to having something that is constricted. Well, then what ends up happening is with the mucus that is being generated, because you were just sick, right? It has no place to go, so it can't drain. Well, then that mucus changes the whole environment of that sinus cavity, which then can promote the development of pathogenic bacteria from the normal bacteria that are supposed to be there doing their job. And so that's when we end up with things getting worse, not better. And then moving on to a fungus, these things are usually really hard to detect because they are something that comes with persistence. And so when we talk about fungal infections of the lungs, this is usually through a process of exclusion. So testing for viruses, testing for bacteria, and then finally testing for fungi. These are persistent ones. These ones are really hard to treat because fungi can develop spores, and spores are difficult to treat, meaning that then when the environment is favorable again, then the infection ramps back up. And so it can be untreated by an antifungal. And so people who end up with like ringworm infections or fingernail infections, toenail infections, those are all different fungal infections. And there's a lot of frustration with being able to treat those because it takes a really long course of treatment in order to start clearing some of that fungus. And then another question to ask yourself is, what are my relevant exposure risks? And so with respect to a virus, were you recently in social gatherings? Were you on public transit? Did you touch something? We as human beings are often touching our face. That's one of the easiest ways for viruses and bacteria to get inside. And then also we've got animal bites. And so this brings up rabies, which we'll talk about on the next slide. And then you have bacteria. It's kind of the same. we have social gatherings, body fluid, and then whether or not there was something questionable. So maybe you ate that piece of spinach and said, whoa, that wasn't very good, but you kept on going because sometimes that happens, right? So that's I have a funny story about food poisoning actually, which is bacterial. So I used to really like to snack on imitation crab meat. Yeah, seafood. And seafood is really bad about this kind of stuff. And so I went and I got my imitation crab meat and I didn't really think anything about it when I got it. It just went in my cart and I went home and then I opened it up and I remember being at home going, huh, this package feels funny. And I ate it. I took a bite and I ate it. And I'm like, that tastes funny. Went in the trash. And that whole night, I spent the entire evening in the bathroom. And it was food poisoning. It was bacterial food poisoning. And so, I was able to figure that out pretty quickly on what had happened and what was the cause of it simply by reflecting back. Now, I didn't have to go to the doctor for anything. I knew what I needed to do. It was rest and hydration, right? Making sure that when I could, I tried to eat a saltine, tried to eat a piece of bread, but it wasn't something that like really clicked until after the fact. And so those are the types of things that we need to consider, as embarrassing as that is, right? Bad job, Nikki. And then fungus. So usually fungi are spread through body contact. And so you see this a lot with like our wrestling community, with our kids that go through wrestling, they end up with some sort of fungal spot. Best thing that you can do is try and treat it when it's as early in the infection as possible. And then the other one is contaminated surfaces, soil. You can get like aspergillosis because you're digging in the dirt, infected dirt. It's not something that you know. And then as a chicken keeper, we've got histoplasmosis. And so so for all the people out there that are raising chickens, be sure that when you're cleaning out those chicken coops, you've got your eye protection, you've got your N95 mask because those are the two most effective ways. Oh, and gloves, two most effective ways to make sure that you don't end up with that fungal lung infection. And so that is actually something that I've always done, with the exception of a couple of times. And then another piece of advice is, try and go through and dampen things before you kick up a whole bunch of dirt because that's where the histoplasmosis is on that dander. And then another one is travel. And so, especially since COVID, I feel like many of us have gotten hit with the question, well, have you visited out of the state in the last 30 days? Have you traveled internationally? And once again, I've got a story about this one too, because why not? So when I was a graduate student, gosh, I did a lot of stuff when I was a graduate student. When I was a graduate student, I came up to Minnesota from Nebraska to visit family. So I was here for the weekend, went out to the lake. We hung out. It was really windy, didn't really do any swimming, but spent some time outside. No big deal, right? So I went back to Nebraska, didn't think anything of it. And a couple days later, I saw in the mirror that I had a big rash right underneath my butt. And so it wasn't anything that was super obvious until like one day I passed by the mirror and I'm like, oh, what's that? And so I didn't do a body check when I came back from Minnesota. And I didn't think anything of it either because I'm just like, well, never happened before. I probably got stung and I didn't realize it, or it was a spider bite and I didn't recognize it, or whatever, right? And then I got really, really sick. So 2 days later, after I first saw that rash, I got really, really sick. And that's when everything started to click again. And so once again, this is like knowledge is power. Once you figure out the different bugs that you can get, learn about them, because then what ended up happening is I went to student health. I went to student health and I walked in and I said, hey, I think I have the early Lyme disease. And I sat down with the physician and she said, well, that really isn't possible because we don't have Lyme in Nebraska. And I said, it just so happens that last weekend I was in Minnesota. And she's like, oh, that changes everything, right? And so being forthcoming with your travel is also sometimes really important for your doctor to be able to get a proper diagnosis. And so things like Lyme disease, it's really important if you're traveling around that you share those types of things. And so after y'all have all of your notes, the important thing is to go and see your health practitioner, because your health practitioner are the people who can order the tests, diagnose, and prescribe if needed. If anything, reach out to them virtually through the message system, because they should know about the things that ails you, and that's important for your medical history, because if something is documented as chronic, that could be the thing that separates effective treatment of a fungal infection, for instance, because it's something that's been documented for years, right? And so when I say your health practitioner, I mean somebody who is a health professional. Those are our MDs, our DOs, our advanced practice registered nurses, including like our NPs, so our nurse practitioners, and also our physician assistants. Make sure that we're seeing properly trained health practitioners, and they'll be able to guide you in your journey. So with that being said, let's talk about expectations, because there is nothing more frustrating going to the doctor and not having anything to be able to do, right? And so let's set up some realistic expectations. One is that many viral infections cannot be treated. So we are forced to treat the symptoms. And that being said, we have some really incredible products that are now available to help treat some of these viruses, especially like influenza A with, why can't I think of it? The antiviral that's specific for influenza A, Tamiflu. And then we've got Paxlovid for COVID. So as the scientific community, and as we support our scientific community in finding different ways to help treat these viral infections, we'll continue to see better treatment for that. But the important note is that antivirals are very specific, meaning that they are specific to one type of virus. And so we don't treat COVID with Tamiflu because it's not effective. Tamiflu is specific to influenza A, and we don't treat influenza A with Paxlovid because Paxlovid is specific to COVID. And so there is no type of real crossover between antivirals like we observe with antibiotics. And another really important thing is, based on the viral life cycle, these must be administered early in infection. Otherwise, they're really not effective. And so if you wait to go in until you're feeling like your absolute worst, chances are you waited too long. And generally speaking, there's no point in giving an antiviral at that point. And so a person needs to be able to go in at the earliest stages of infection in order for these antivirals to be effective. And with that being said, that might lead a person to believe like, hey, we should just wait and see, right? I'm saying, no, don't just wait and see. At the earliest signs of infection, if you know that you've been exposed to influenza A, get a hold of your doctor, because they might be able to help, right? But one that is an absolute do not wait and see is rabies, because that has a near 100% treatment rate if treated within the first, I think it's 48 hours, and almost 100% mortality rate if it's not caught within 48 hours. And this is post-exposure prophylaxis, and that is a treatment of first immunoglobulins. And so that is to find the rabies virus immediately. And then it is a series of 4 vaccines that are given within, I think, a 7-day or a 2-week. I can't remember which it is. Once again, another fun story from grad school. So I lived in a 100-year-old house when I was in grad school, and this thing was old and it had some holes. And so I had a whole colony of bats that lived in my attic. And it was not a big deal because the bats were in my attic and I was in my house, and there was no crossover, right? Until there was. And so the bats managed to make it into my ductwork and made it throughout my home. And one evening I woke up to the sound of wings in my bedroom. Um, and I didn't think anything of it until I was speaking with my neighbors. And so this is, important. Also, talk with your neighbors about what's going on, especially when you're living in a more densely populated area. And I said, yeah, last night I woke up with bats in my bedroom. And she's like, oh my gosh, you have to go in because so and so just down the road had their bat tested that ended up inside their house and it had rabies. And so the general consensus is that if you do not know if you have been bit, or if you are bit by a wild animal or any animal that has a questionable vaccination status for rabies, go in immediately because the alternative can be death. And so I did. I went into student health, took my butt right in there, and I said, I woke up with a bat in my room last night. And they said, okay, let me get um what was it? They got somebody on the phone and they said, yep, administer that rabies protocol immediately. And so then after that, then everything had to be done in such a way that I got the bats out of my house. So yeah, so that's yet another Nikki graduate school story. So just be smart about your exposures, I guess is what that comes down to. So then let's flip gears and talk about bacteria. And I hear it over and over again. Well, I went into the doctor and my doctor didn't prescribe me anything for my sinus infection. Well, that's frustrating, but know that so many bacterial infections can also clear without antibiotics. And there is a significant risk to using antibiotics. And so if you have a history of using antibiotics, your physician will almost certainly try and keep you from using them because sinus infections are generally a comfort issue. Um, and repeat administration of antibiotics is the main driver for bacterial resistance. That's why we have superbugs out there. We've got MRSA, so methicillin-resistant Staphylococcus aureus. We've got MRSA, vancomycin-resistant Staphylococcus aureus. And then we also have like superbugs that are STDs. So we've got a superbug that's chlamydia. Can you imagine getting an STD and not being able to treat it? But that's what's going on, and those are the types of reasons why there's been like this big shutdown of administering antibiotics willy-nilly. It's because these are the things that are being seen, and there is nothing worse than not having an option to treat something because we are running out of antibiotics. Because unlike antivirals, our antibiotics are generally less specific. They're specific to a specific class of bacteria. So it might be the gram positive, it might be the gram negative, it might be spirochetes. So these antibiotics are specific to different groups of bacteria. But once those groups develop resistance, then we can't use those antibiotics anymore. And it's not just a matter of time. Those resistance, or that general resistance, is something that's going to be held onto. And then as those pathogenic bacteria then spread through the community, that's how we end up with a whole community not being able to receive proper antibiotic treatment. And so, with respect to sinus pressure, of course, I can't give medical advice, but if you were to talk to your physician, what they would probably recommend is decongestants. And so decongestants like Sudafed are really good at helping with the inflammation of those sinus cavities. And so once you open up those ducts, then it's just a matter of time to get that mucus flushed out because our sinus cavities are capable of getting that mucus out. And so once everything gets opened up and you give it some time, then eventually you're going to feel better. Eventually. And then, depending on what is the reason for that sinus infection, if it's an opportunistic infection that follows a cold, your best bet is your decongestants. But if it's something that you have like really terrible allergies, I used to end up with a sinus infection every spring when the pollen came out. And for that, treat it with treat your allergies, and that would be some sort of antihistamine that you feel works best for you. For me, it's Benadryl, but that's super fun with the side effects, right? And so once again, here's that sinusitis, and so a decongestant targets some of these smaller areas and helps alleviate that congestion that takes place right here. And then with respect to a chest cold, because people get those too, you end up with a lot of mucus there. The best thing that you can take is something like an expectorant. And so that would be like your Mucinex. Depending on the guidance that you get from your health practitioner, they might also say you should take a cough suppressant. Usually, though, you want to get that mucus out. And so don't take that cough suppressant because the mucus doesn't go anywhere then. It just gets loosened up. Um, Once again, an absolute do not wait and see is if you suspect you have pneumonia. And so for that one, you want to go into either your primary health practitioner, the ER, or the urgent care to be properly evaluated. But generally speaking, whether it's virus or bacteria, the big things are to rest, stay hydrated, and find ways to soothe the symptoms. And so if it's throat-related stuff, you can sleep with a humidifier. Saltwater gargles seem to help. They even have steam mechanisms. So they've got vaporizers so that you can breathe in warm steam or cold steam, depending on what feels best. And then, of course, there's the aftercare, making sure that you're eating a balanced diet, you're getting the exercise that you need, the different things that we just need to do in order to take best care of our bodies. So, our last tidbit. Okay, I've got a virus. Why doesn't an antibiotic work, right? And it's because antibiotics are very specific. They target the cell walls of bacteria, which look very different than a virus or even a human. And it can target either the cell walls or the replication machinery. And so here, a little bit of science for you. We have a gram-positive bacteria, gram-negative bacteria, and contrast that with what would end up looking like a human. Granted, I just went through and I cropped this, but this is what our human membranes look like. And a virus also has some of our same human components because they end up stealing their envelope from our cells as they're budding off, which is kind of neat. And so they too have these membrane bilayers, phospholipid bilayers. And another thing is that viruses are often intracellular. Antibiotics or bacteria aren't. And so it's really hard for these antibiotics to get inside the human cell when they're specifically targeting bacterial cells, right? And so what they're targeting are these types of things on the very outer surface of the bacteria, not the phospholipid bilayer. So why can't I use antibiotics just in case that point hadn't been made completely clear? You don't want to do it just in case because you're driving resistance. And at any time, normal bacteria can become pathogenic depending on its environment that it's in. And yeah, the exposure of bacteria to antibiotics drives the resistance. And on that note, it's also important to say if you are prescribed an antibiotic, make sure that you're taking it to its completion because it doesn't take much in order to develop that resistance. And so if you're taking it only until you feel better, there is a very high likelihood that you have bacteria, pathogenic bacteria, just not at the level of causing active infection. But those bacteria are more likely then to develop the resistance that we're talking about. And so making sure that you take that antibiotic till it's completely gone is absolutely essential. And then as a last note, I talk with everyone I can about this because as a patient, it is your responsibility to be your own best advocate. That's not going into the doctor and telling them how to do their job, but saying, hey, this is completely different for me, and I need you to take this seriously. I'm not, not coming in a week after being sick. I am sick right here, right now, and this is not right. And so this is especially paramount when you're seeing somebody who's not your primary. And so if you're headed to the urgent care, an ER, or if you're setting up an appointment with somebody that you don't usually see, um, making sure that you give all of your medical history that you feel is most important. So those notes that we talked about, that is all of the stuff that they need to know because they only know what they know, right? And not every physician is going to have the time it takes to go through the nooks and crannies of a person's health history, if your health history looks like that. And so you can even go so far as to say, hey, I would like to be tested. I would like to be tested. They have a quad test now for COVID, flu A, flu B, and RSV. It's a pretty easy to administer test. Alternatively, if you're somebody that has a suspicion that you were exposed to strep and dealing with strep throat-like symptoms, even if you don't present with some of the usual symptoms like the white patches, you can say, hey, I'd like to rule out strep. Because if you don't treat strep, bad things can happen. And so being able to catch that at its earliest stage of infection is really important. So let's say that you have a kid that went to school that sometimes shared water bottles with somebody who then ended up sick, and you find out, hey, the kid that shares their water bottle came down with strep. Take that to the doctor and say, I think that my kid might have strep, because sometimes they do. Because kids are kids and that's what they do. They do gross things like share water bottles. And then there's also another thing is, if you think that it's pneumonia, there's nothing wrong with saying, this is totally not my normal. I would like x-rays. And or what do you think about x-rays? And this is something that we found out about within our own family. Once again, another story. Um, my husband was dealing with this really terrible cough, and he had a flu, and he was feverish, and he was just totally not himself. And finally I said, okay, we're not going to do this wait and see. I don't like it. We're not doing it anymore. We took him to the urgent care, and at the urgent care, I told him, you're doing this. I've got the kids. You're doing this. You're going to ask to have x-rays. And he got the x-rays, and then he was sent away. And it's just like, oh yeah, we don't really see anything, but we'll have the radiologist take a good look, and come to find out that it was in fact pneumonia. And so then all of a sudden the antibiotics were prescribed. We went back into town because of course we didn't hear back until after the pharmacies up here had been closed, and all of that kind of stuff that comes with just the drama of living in rural Minnesota. But being your own personal advocate in your health journey is really, really important. And it is a fine line to walk, because nobody wants to be told how to do their job either. And so being mindful of the fact that your health professional has a ton and ton of training and experience, but saying, hey, you know what? This is really, really off for me. I need to be properly tested. There's nothing wrong with that. So with that, I thank everyone for joining. Let's see if we have any questions. Do you have questions? Probably. All right. Let's see. Oh, I bet you I don't have it on my phone. I'll have to flip over. Whoop, that's viral envelopes. We don't need that. Where did Zoom go? Um, Screen sharing, chat. We don't have anything in the chat. All right. So this is kind of served as a primer for next week. So next week we'll get a little bit deeper into the science of viruses, because not all viruses are the same, right? And I think it's really important this time that we distinguish the difference between viruses and bacteria, and why we can't treat viruses like we do bacteria. Hopefully that part was made clear. But next week we'll talk a little bit more about, why we can't treat COVID like influenza, why vaccines need boosters. We'll talk about antigenic drift and antigenic shift, and why, we need to get an annual flu shot if you want to have some protection from influenza. And, this year is a bad match. But what they are seeing is that people who were vaccinated that came down with influenza came down with a much less severe form of influenza. And so having proper uh, vaccination does matter. So, yeah. So this has hopefully been a primer for that. Cool. All right. So with that, I am going to shut her down.